I'm Marc de Perrot. I'm a thoracic surgeon at the Toronto General Hospital. I'm in charge of the chronic thromboembolic pulmonary hypertension activity at the Toronto General Hospital University Health Network. I'm a thoracic surgeon performing the pulmonary thromboembolic as a treatment for chronic thromboembolic pulmonary hypertension, or CTEPH. So I've been working in the field of pulmonary hypertension for almost 20 years. Initially started working in the context of pulmonary hypertension as a lung transplant surgeon. And that's how I got involved in PH. And then we were seeing some patients with chronic thromboembolic pulmonary hypertension referred for lung transplantation, and the surgery of pulmonary thromboembolic has improved in success and eventually was becoming the treatment of choice, and that's how got involved more directly in CTEPH. The pulmonary endarterectomy is a curative treatment for CTEPH. It was a much better option than the lung transplantation, which has some difficulty and some limitation in the long term. So the pulmonary endarterectomy or thromboendarterectomy was clearly a much better option for patients with CTEPH, and it was important that the patients were referred for the right surgery. And that's how I started the pulmonary thromboembolic program at the Toronto General Hospital back in 2005. The meaning of chronic thromboembolic pulmonary hypertension, or CTEPH, is two things. One is the pulmonary hypertension, and the cause of pulmonary hypertension is chronic thromboembolic disease. So these are patients who have a history of pulmonary emboli, and the emboli leads to scarring of the vessel of the lung, which eventually leads to the pulmonary hypertension. So it's really the combination of the pulmonary emboli and the development of pulmonary hypertension that leads to the diagnosis. The important part is that chronic thromboembolic pulmonary hypertension, or CTEPH, is the only curative form of pulmonary hypertension, and therefore it is critical that it is diagnosed properly in order to give a chance of cure to patients with PH, which they may not have otherwise. CTEPH, like any form of pulmonary hypertension, the symptoms are not very specific. So the main symptoms is shortness of breath or dyspnea. Patients feel short of breath going up a flight of stairs. A lot of the time they will attribute that to some deconditioning and getting older. So to make the diagnosis, CTEPH is sometimes taking a long time, like it can take about a year for eventually the diagnosis to be made. That is similar to pulmonary hypertension in the sense that the symptoms are very non-specific and very similar. The difference in CTEPH compared to other patients with PH is that CTEPH patients typically are relatively or in their 50s, 60s, or 70 years old, or sometimes 80 years old, and develop the disease. So it's a condition that tends to be developing later on in life, in contrast to pulmonary arterial hypertension, which can occur more frequently in younger patients. So a lot of the time, the symptoms are quite similar to patients with emphysema, COPD, pulmonary fibrosis. So the differential diagnosis of CTEPH doesn't necessarily come up at the top of the list, and it does take some time for the patient to be diagnosed occasionally. On the other hand, once anybody who has a diagnosis of pulmonary hypertension needs to be evaluated for CTEPH in order to ensure that the diagnosis of CTEPH is made if pulmonary hypertension is diagnosed. Again, since this is the only form of PH that is potentially curative. The symptoms of shortness of breath is very non-specific, and a lot of the time, shortness of breath leads to evaluation of the lung. So the lung is looked at very carefully, but the vessel of the lungs takes extra investigation in order to be evaluated. So unless you evaluate the vasculature of the lungs, you may miss the diagnosis of pulmonary hypertension, despite the fact that the symptoms are shortness of breath. So anybody with shortness of breath should be evaluated for their lung function, but also from the pulmonary vascular perspective, For the CTEPH part, the main initial test is a ventilation perfusion scan. So you assess the perfusion of the lung and you assess the ventilation of the lung. And if you see a mismatch of the perfusion, then you start other investigation for potential diagnosis of CTEPH. It's not something that physicians think of as a potential cause of shortness of breath. So one of the critical parts is to increase awareness about the possibility of CTEPH as being a cause of dyspnea. And the second step is to do the right test to rule in or rule out CTEPH. And the first step is to do a ventilation perfusion scan, which is really the best test to have a screening tool to evaluate the possibility of CTEPH. So it's really to think about the diagnosis and then do the right test in order to make your diagnosis. If the ventilation perfusion scan is abnormal, that is enough to warrant a referral to a specialized center treating patients with CTEPH. The early diagnosis of CTEPH or pulmonary hypertension is quite critical in the sense that the evolution of the disease has an impact on the heart. So patients eventually develop heart failure as part of the natural progression of the disease. So the early diagnosis of pulmonary hypertension allows the treatment to be started before the heart failure starts to become a problem, and the success of the treatment is much better. From a CTEPH perspective, this is even more critical in the sense that the CTEPH is treated with surgery, the pulmonary thromboembolic, and the development of the heart failure does increase the risk of the surgery by up to tenfold. So the early diagnosis of CTEPH can lead to a much better results from a curative perspective with the pulmonary endarterectomy, and also limit the risk of the surgery to a much lower risk. So the surgery is much safer and the success in the long term is much better from a curative perspective. The diagnosis of CTEPH is potentially linked to pulmonary emboli, so there's a lot of research to be done in order to follow some patients with pulmonary emboli, an acute event, in order to make sure that the resolution of the pulmonary emboli is complete, and if not, to be able to make an earlier diagnosis of CTEPH, and potentially to eventually prevent the development of the pulmonary hypertension once you've had a blood clot. So the CTEPH currently is treated predominantly with the surgery, the pulmonary thromboembolic, and we, in the field of CTEPH, are developing new technique and technology in order to treat the disease without the surgery with minimally invasive approach. So you can go into the vessel of the lung, inflate a balloon in order to enlarge the vessel, and to potentially also cure patients with CTEPH with a minimally invasive approach. So this is a new field that is developing. So there is a lot of potential development in that direction in order to potentially cure the disease without the surgery, but with a minimally invasive treatment. As the disease is diagnosed earlier, the success of this new technology is certainly going to become much better as well in order to prevent the development of pulmonary hypertension, potentially even if the disease is catch up at a stage where the pulmonary hypertension is not yet even present, but we can see the parameters that potentially will lead to the pulmonary hypertension. So that's where the field is progressively evolving towards. If you have somebody with shortness of breath, you should think of the pulmonary vascular disease and investigate it with either a CT pulmonary angiogram or a VQ scan as part of your evaluation, and an echocardiogram as well as part of the evaluation for pulmonary hypertension. So anybody with shortness of breath, unless there is a very clear cause for the shortness of breath, should have an echocardiogram and an evaluation of the pulmonary vascular disease with some imaging. I am Dr. Marc de Perrot, and I am aware that I am rare.